Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast today. My name is Terry Fletcher. So we are in our second Tuesday of September, and I'm pretty excited. We finally got some relief from the hot weather. We were in the hundreds and 90s for a while, but now we're down to the mid 80s, which is not too intolerable. Except we are having a little bit of a windstorm today here in Southern California, but hopefully that'll pass. But if you hear anything kind of in the background, that's what it is. It's wind, even though I have my windows closed. So I hope everyone's doing well. Today my topic is going to venture off just a little bit into coding compliance and just some of the things that are coming up. But first, I'd like to get into some things with telehealth because we have a telehealth live webinar coming up on September 18th, and it'll be at 7 a.m. Pacific time, 10 a.m. Eastern Standard Time, and there is an Eventbrite link to that. Also on my website, go to terryfletcher.net and go to the webinar seminar page, and it's right there. Just scroll down and you'll see it. So hopefully you'll join us, because remember, we're going to get a lot of changes coming in less than a month. And so we have not seen any movement from Congress. There's no new congressional bills to extend anything as far as the geographic location or certain providers being able to provide telehealth. So when they say, oh, we've added more services to the telehealth list, that's for qualified telehealth providers and qualified locations. So we're going to have to go back to things called the distant site, the originating site. And if you don't know what that is, because I know a lot of you have been or did start in telehealth after the pandemic in 2020, you probably don't know what the pre-pandemic rules are. But that's what I'm here for. That's what Stephanie's here for, and we'll be able to give you all that information. So anyway, check that out, terryfletcher.net. Go to the webinar page, and you'll find how to register. Okay, so let's get into my topics for today. I've got a couple of things I wanted to go over with you. Just some things that came out. I don't have a top 10 this month. I didn't have one last month because I was trying to get to some other things, but I do have some questions that came in that I wanted to address. So here's a really good one, and it's talking about medical decision-making for major surgery, trying to get to a level 5 versus a level 3, which is elective major surgery without identified patient or procedural risk factors. Now they mean the risk factors to the individual patient. Every surgery has risk factors, so your canned macro phrase is not what they're talking about. When I talk about them, I mean AMA. To get to the higher levels of service, again, it has to be individual to the patient. So it must be relevant to the patient and the procedure. When you're talking about major surgery with risk factors, for example, patient is going in for a total knee surgery or a revision of total knee, and they have a history of MRSA, so they have a greater risk of infection. Patient has diabetes and is scheduled for major spine surgery, so they have potentially a greater risk of healing and infection. But you have to make that link as a provider. Even though I'm a clinician, or I should say a former clinician, you can't make it for them. Even for those of you that are auditors and coders out there as well, you can't make the leap for the provider. They have to do it. And they can't do it as a canned phrase. Not every diabetic patient, not every patient who has a history of something is going to be a greater risk. Does this patient have that risk? Let's say the patient's going to have spine surgery and they've been a smoker for 30 years. Will that place the patient at greater risk for healing than the average patient? Potentially, yes. What about the patient who's been on Plavix, but this has been discontinued for the procedure? That's a blood thinner. But are they still at risk for potentially bleeding? Yeah. So anything like that, where certain comorbidities are something that your doctor, and I'm air quoting, addresses, then yes, those are, the on the risk of complications or morbidity or mortality of patient management. Those are the things you'd want to see for that third element of the E&M to be able to say that part is high risk. Now, you still have to meet 2 out of 3 elements, so you still have to have it in numbers and complexity of problems addressed, or possibly in the data reviewed and analyzed. And again, it can't be any data that, you billed for and get paid for, or old data that you've already reviewed. You only get credit for it once. You don't get it every single time the patient comes in, which I know a lot of practices are trying to do, and the payers are trying to, or finally catching up to that. So just know it's 2 out of 3, but when we're talking about the risk of the third element, when we're talking about major surgery or decision for major surgery and the risk factor, it has to be specific to that patient outside the general risk that, surgeries have. Okay, another one. So this has come up a couple times, and I was looking at the Coding Intel site on this, and I thought this was interesting because there was a code that came out, 99459, and that is what we use for a pelvic exam, additional supplies, or person needed when, again, a pelvic exam or pap smear is being done. But there was a question that came up in the July 2025 CPT assistant, and it said, about whether the 99459 could be used on a male patient for an examination of external male genitalia and a digital rectal exam. They said no. Remember, this is for a female patient, okay, and it's a pelvic exam to cover additional supplies needed to provide the service, speculum, etc. And this is also specific to clarifying supervising a staff member. They actually said if you do, or you may need to, but it's not required to report that, so it's just the extra cost of what you have as far as those services. But, it can be confusing as far as trying to open the scope, forgive the pun, to try and get something there. But this is not new news. This is just something that I think was bulleted and updated by CPT assistant, thinking, okay, well, we thought that the definition of the code kind of spelled it out, but apparently not. So billing for pap smears in a physician practices, pap smears can be screening services or diagnostic. There's a HCPCS code for obtaining a screening pap smear, Q0091. Performing a pelvic exam is either part of a preventative medicine service or a problem-oriented visit, so you wouldn't get extra for that. But the CPT code for the pelvic exam, again, it's for PE, which is practice expense only, the 99459. It's add-on code to either the preventative or if it is gynecological E&M service. So hopefully that cleared up any confusion you may have had about that. Now another one came in, and I appreciate this from one of my Coding Corner clients, but I think she was kind of overthinking it just a little bit because we kept going back and forth, and I don't know how much more I could have answered the same question over and over again. But the question came in as far as suspected diagnoses. Can you put in a suspected, ruled out, possible, probable diagnosis and bill it out if you think the patient could have it? Well, unfortunately, yes, if the patient is inpatient. So on the general reporting requirements, so ICD-10 official guidelines for coding and reporting, fiscal year 2025, page 107 of 120, it's at H. It says uncertain diagnosis. If the diagnosis documented at the time of discharge is qualified as probable, suspected, likely, questionable, possible, or still to be ruled out, compatible with, consistent with, or other similar terms indicating uncertainty, code the condition as if it existed or was established. That's interesting, right? So the basis for these guidelines are the diagnostic workup, arrangements for further workup or observation, and initial therapeutic approach that corresponds most closely with the established diagnosis. But then there is a note in bold. This guideline is applicable only to inpatient admissions to short-term, acute, long-term care and psychiatric hospitals. So you can't do this in the office. In the office, they expect you to know patients there electively. They're coming in, figure it out. But in the hospital, where it always reminds me of that TV show House, where they have no idea what's going on with the patient, so they suspect something. They suspect sepsis. They suspect, a UTI that led to this. They suspect, the chest pain could be this. They suspect the abdominal pain could be appendicitis. But it's interesting because I just got a light bulb above my head, which I didn't really see this before. It says, if the diagnosis documented at the time of discharge is qualified as this, so probable, suspected, and so on. So I guess the expectation is that the hospital visits are not going to be billed on a daily basis. They're going to be billed after the patient's discharged, and then it's appropriate. I could see that argument now as I'm looking at this. So at first I didn't see that, but as soon as I read it out loud, I was like, at the time of discharge. So keep that in mind. And I think the back and forth was just we are coding and billing the professional radiology claims of place of service 21. Is that when an uncertain diagnosis can be applied in this case? Yes. So, but again, look at the verbatim at time of discharge, because that is going to be key if you have to follow up or appeal anything where they said, no, you need a specific diagnosis. So those are the updates that I really wanted to kind of go over today, only because it's just crazy when we get some ambiguity or some gray areas or things we don't know how the payer is going to have it play out when it comes to certain services. And so, when we submit our ICD-10 codes or we submit our CPT codes, but I'm just seeing so many things right now that on audits that, my list is long. I'm seeing misuse of shared visits. I'm going to go over that again in an episode coming up soon. For those practices that have weight loss clinics, oh my gosh, some of the non-compliance there is kind of crazy. The biggest thing I'm seeing right now is diagnosis order. Let's say that you have a hospitalist on your staff and the patient was admitted because they had a stroke or cerebral hemorrhage, or they slipped and fell and had a fractured femur, hip, whatever. But that provider, specialty provider, that's what they admitted them for. And now the hospitalist is just going in and checking on whatever medical unrelated to that is necessary. You can't use the diagnosis that you're not following, you're not addressing, you're not dealing with as your primary diagnosis. So keep that in mind, and because I'm also seeing that with other specialty providers that are rounding on patients. Patient comes in and they've got, I'll go back to that femur fracture, and you got a pulmonologist trying to use that diagnosis. Well, they're only going to pay one provider per day for that inpatient diagnosis. They're not going to pay a pulmonologist to look at a hip fracture. Now, if the pulmonologist was called in because the patient, they felt that there was maybe some sepsis or there was a problem with their lab values, or they felt that there was a question as far as what pain meds they could use because of some of the medications they were on for maybe a cardiac issue, then I understand that. But you have to also, read the room, understand what the specialty provider, who they are, before you kind of go out on a limb there, because that would be a problem. And then lastly, I just want to remind everybody, it's September 9th. The ICD-10 codes become available October 1st. Also, our CPT books from AMA get shipped in the middle of, towards the third week of October. So order your books now. You can still get discounts on them if you order them before September 15th. AMA is kind of pricey. You can get them there, but I would look to AAPC. You can even get them on Amazon now. But I would definitely get the spiral bound book for CPT. If you also get it to where you're only pulling it up online, that's totally fine. But I have mine on my desk. I'm right-handed, so it's on the left side of my desk, and I use it every single day. I also tab it. I know where to look for things. I highlight it, because there are times when I just need to go back and say, oh, that's where that is. And you can't always do that with an online book. Get both if it's easier, but I still strongly recommend you get the paper version. But that's up to you. Maybe I'm just old school, but I need my book. Okay, well, everyone, I'm excited because we have NFL season starting. Make sure you check out the Steel City Underground podcast for the What the Football, WTF. Be doing it weekly. Should drop around Wednesday every week, so hopefully you'll check it out. So everyone, make it a great rest of your week. Make it a great day, and thank you for listening to the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.